Yes, the talk allotted to me today is regarding flashes and floaters, and I have been told to tune in the talk for a general ophthalmologist. Thank you, scientific committee, for allowing me to be part of this program. The incidence of retinal detachment is 1 in 10,000 people over a year. It's a relatively rare phenomenon, and the symptoms the patient presents with is, although not specific for retinal detachment, and differentiation from other ophthalmic conditions is very difficult without a dilated fundus examination. The urgency of referral to an ophthalmologist is to exclude a retinal detachment as well as identify and treat retinal tears, especially in patients with high risk of posterior vitreous detachment. So we should always remember that the patient has come to us with a warning symptom, and it may be very costly both for us as well as the patient to miss this warning symptom and miss the retinal pathology. To understand the pathophysiology of this symptom, we know that for the posterior segment, a healthy vitreous may correlate with a healthy eye. It functions very well to give an optically clear media with no light interference passing up to the retina. However, as the vitreous degenerates, there is a loss of transparency initially in focal areas because of a loss of balance between hyaluronic acid and the collagen fibers. The collagen fibrils get clumped together and the fluid gets separated. The focal disturbance caused because of this, because of the shadow falling onto the retina, may present in different forms. It may be minimal floaters, and the density of floaters changes as the opacity goes closer to the retinal surface. The closer it is, the darker and sharper it is. The shape of the floaters may also differ according to the pathology. As this process progresses, the vitreous gel collapses, and another anatomical change which occurs in the vitreous is the separation of the posterior hyaloid from the retinal surface. As it's mostly an age-related phenomena, patients who are over the age of 70 years, they present symptomatically with flashes and floaters, and PVD is noted in the majority of these patients. As the vitreous separates from the retina, the vitreous gets a bit mobile. It may tug onto the retinal surface. It may also bang on the retinal surface, causing flashes of light for the patient, which is very, very alarming. Now, although vitreous detachment is an age-related phenomena, we should understand that it comes very early on in myopic patients, especially the higher myopes. And with aggressive refractive surgery is being done, 10% incidence has been noted in post-LASIK patients, which is important to note. In addition to the age-related phenomena, it is also noted because of trauma, because of surgery, as well as because of inflammation. Important to note is in these symptomatic patients, 14% may be having a retinal break. In the majority though, the vitreous collapses anteriorly to form a body in the anterior vitreous. It remains attached at the vitreous base, straddling the ora serrata. It's when there are abnormal posterior extensions at the vitreous base that traction may be implied onto the retinal surface, causing tears at the posterior edge of the vitreous base. As the posterior hyaloid separates, it may also pull on to adhesions between the vitreous and the retina, some normal, some abnormal. And as it separates, sometimes there is liberation of either blood into the vitreous cavity, or if there is a retinal tear, the pigment epithelium gets exposed to the vitreous cavity, releasing pigment into the vitreous. It is very important to note on slit lamp examination, it's a very important sign called by the name of Schaffer's sign that this patient may likely have a retinal pathology. On good examination, you may see the Weiss's ring, which is exactly the size of the edge of the optic disc from where the glial tissue separates as the vitreous detaches. Some patients may present with vitreous hemorrhage. It's important to note that 70% may have a single or multiple break in these patients, and a majority of these may go on to progress to form a retinal detachment later. So it's very important to examine these patients. In our clinical examination, other clues may be indicative of something more alarming. We should remember that the pathology is usually in the peripheral retina, and so it's a must for either us to learn indirect ophthalmoscopy and do a dynamic depressed examination, gentle if there is presentation of hemorrhage, but this part of the examination is not to be overlooked. At this point of examination of a patient, I will emphasize on correct communication with a correct message to the patient. We should explain to the patient that posterior vitreous detachment is a process which goes on for almost 2 to 3 months. Although normal today, a tear may develop later and a repeat examination is mandatory. 3 to 4% of patients may develop a tear over this period. He also has to be warned, fresh floaters, fresh flashes, he should report early to you. So in the majority, the posterior vitreous detachment may culminate into just asymptomatic posterior vitreous detachments as the symptoms fade off, or there may be a lingering peripheral pathology which may be blinding for the patient. We should emphasize that such a patient needs an urgent dilated fundus examination, and if need be for the correlating pathology, a same-day referral to a retina practitioner to intervene early. I will emphasize for medico-legal reasons to note your findings as well as in short a small message what we have conveyed to a patient. Some patients, however, may present to us with a retinal detachment. We should emphasize to these patients as a general ophthalmologist that he needs early intervention. It is operable with very good success rates, and we can help the patient schedule an immediate appointment with a retinal surgeon. So to re-emphasize, in a majority, PVD is a normal process of aging, and you can neglect the symptoms if the patient has these symptoms mostly for a long time. Vision has been good and flashes have eventually stopped. But if it is alarming with new increased flashes and floaters, if there is a dark curtain or shadow moving across, if the patient has floaters after eye surgery or eye injury, it has to be looked into. Higher risk category of individuals with high myopes, post-cataract surgery, or history of retinal problems earlier need to be looked into. Again, to emphasize indirect ophthalmoscopy, good counseling, and to refer or treat these patients in time, very, very important. Posterior vitreous detachment needs to be followed up again after 2 or 3 months to emphasize and clear that there is no pathology present. A break, if in an attached retina, can be treated with retinopexy, or a definitive procedure may be done for a retinal detachment. Just to complete my talk, there may be other reasons for flashes of light for a patient, but this does not come under the purview of my talk, which is directed more so towards targeted patients of retinal detachment.
Dr. Bhushan, you'll have to
Thank
wind
you.
up.